In this session on the reproductive system, we're going to look at gestational diabetes mellitus. And gestational diabetes mellitus is really type 2 diabetes mellitus during pregnancy. But also it tends to resolve after giving birth. Of course it does, because the gestation has ended. But it does make individuals more susceptible to type 2 diabetes mellitus, for example. So the key aspects that we're going to cover in this session, we're going to look at the mechanisms of insulin resistance in a normal pregnancy. And to do this, we will have to think about insulin signaling, how insulin affects the intracellular pathways within cells, within adipose tissue and the liver and the skeletal muscle, for example. We'll then talk about the pathophysiology of gestational diabetes mellitus itself. So if we're thinking about gestational diabetes, it's relatively common. And it's a glucose intolerance that begins or is first recognized during the pregnancy, and it affects 5 to 7% of pregnancies. So it's really quite common. The hypoglycemia becomes apparent at around about 24 to 28 weeks, and it increases the mother's risk of preeclampsia, of type 2 diabetes, and the requirement for a C-section. And it increases the child's risk of multiple problems, so hypoglycemia at birth, for example, increased laying down of fat, and type 2 diabetes mellitus later on. And I want you to just press pause at this point and have a think, why is there an increased risk for the child of hypoglycemia at birth, laying down of fat, and type 2 diabetes mellitus? Now, of course, in gestational diabetes, you will get an increase in blood glucose levels. This means that you will get an increased blood glucose going to the baby. And this, by its very nature, means that you'll get an increased laying down of fat in the fetus because of an increase in fetal insulin being released from the immature pancreas of the fetus. And so therefore, the increased insulin during gestation, dealing with that high blood glucose, aligned with the removal of the placenta, leads to a drop in the high glucose, but the insulin levels are still high. Hence why you're more susceptible, or the child is more at risk of hypoglycemia at birth. What about the increased laying down of fat? Well, of course, insulin, which there is an excess of within the baby, stimulates glucose uptake into adipocytes and stimulates the conversion into triglycerides and therefore fat levels. Why are they more susceptible to type 2 diabetes mellitus later on? Well, basically, you're stressing an immature pancreas because of that increased glucose, leading to excessive insulin release, but also the longer term, or the hypoglycemic damage that is occurring. Remember, prolonged hypoglycemia damages all manner of cells and tissues. And interestingly, women with gestational diabetes mellitus have an increased risk of type 2 diabetes mellitus of about 50% within 20 years. So there's a significant risk of type 2 diabetes mellitus. So what are some of those risk factors? Some of them are modifiable, some of them are non-modifiable. So of course, the things you can't do anything about, your ethnicity, for example, your age, your family history, previous unexplained stillbirth, and a mother with gestational diabetes. There's nothing that can be done about that. But there are modifiable risk factors, such as obesity. So just being overweight, a BMI of 25 to 29, increases the risk of gestational diabetes just over twofold. Being obese, that's BMI of 30 to 34, increases it by 3.5 to fourfold. And being morbidly obese, which is a BMI greater than 35, increases that risk somewhere between 8 and 10 times. So significant increase in gestational diabetes mellitus risk. And other modifiable risk factors include subsequent pregnancies. You don't have to get pregnant, obviously. Physical activity, how much exercise, how active are you? Smoking, and your diet, so sugar and fat levels, for example. So when we're thinking about insulin resistance in pregnancy, it is actually normal. It is a normal phenomenon emerging in the second trimester, and it functions to do a couple of things. It secures sufficient glucose supply to the developing fetus. You need to deliver nutrients to the baby. And it helps to avoid maternal hypoglycemia. But of course, during gestational diabetes, there appears to be an unexplained reduction in insulin secretion. So if insulin secretion is increased and is maintained throughout pregnancy, the mother will develop gestational diabetes because blood glucose levels rise. And this can usually be managed through diet control, exercise advice, and anti-diabetic drugs as necessary. But remember what I said, during gestational diabetes, there does appear to be an unexplained reduction in insulin secretion. So this is your insulin signaling pathway, and it's important to understand the insulin signaling pathway to understand some of the mechanisms in gestational diabetes. So insulin, little yellow splodge in the left-hand corner, binds to the insulin receptor. That's your IR. That causes the insulin receptor to become phosphorylated. It's called autophosphorylation because it phosphorylates itself once insulin binds, and it does this on tyrosine residues. And this activates a tyrosine kinase activity, so it can now phosphorylate other things. And what it does, it phosphorylates IRS1. That just stands for insulin receptor substrate 1. It also phosphorylates other things as well. And this IRS1 serves as a docking protein for your PI3 kinase, which therefore becomes activated. And then there's a whole cascade of downstream signaling events mediated through AKT, which is also called protein kinase B, but AKT, and it stimulates a whole downstream network of pathways. So it stimulates the translocation of intracellular GLUT4 glucose transporters to the plasma membrane, and that occurs in both skeletal muscle and adipose tissue, not in the liver. We therefore get increased glucose transport into the cells. It also stimulates glycogen synthesis and degraces glycogen breakdown. It also, when we're thinking about the liver, decreases gluconeogenesis in the liver. So this is what insulin is doing. So insulin is targeting glucose uptake into your adipose tissue and your skeletal muscle. It stimulates glycogen synthesis. It prevents glycogen breakdown, and it prevents gluconeogenesis in the liver. And of course, it also stimulates triglyceride synthesis and the laying down of fat. Now, the placenta secretes lots of things, and we've talked about some of them previously: estrogens, progesterones, CRH, corticotrophic releasing hormone, etc. But it also secretes something called tumor necrosis factor, or TNF-alpha. And TNF-alpha causes insulin resistance. It causes insulin resistance in obesity as well. And what it does, it inhibits IRS1 activation. So if you remember, insulin binds to the insulin receptor. That activated insulin receptor then activates IRS1, but TNF-alpha inhibits it. So as you're pregnant and the placenta develops, you produce more tumor necrosis factor alpha, TNF-alpha, which inactivates IRS1. Therefore, you get a reduction in the insulin signal transduction pathway. In other words, you're getting insulin resistance. And because you're getting insulin resistance, you get a decrease in glycogen synthesis. You get a decrease in GLUT4 transport to the plasma membrane in your skeletal muscle and your adipose tissue. And therefore, your blood glucose levels rise. So in other words, insulin resistance in a normal pregnancy leads to hyperglycemia, which increases the nutrient delivery to the fetus. But of course, tumor necrosis factor is produced by the placenta, but it's also produced by adipose tissue, which is why obesity has such a large role. So the more obese you are, the more tumor necrosis factor that you produce. And therefore, the more tumor necrosis factor that you produce, the greater the level of insulin resistance you get, and therefore the greater the amount of hyperglycemia you get, which can lead to your gestational diabetes mellitus. So remembering what's happened, here's our little diagram where we have activation of the insulin receptor, activating insulin receptor substrate, and then all these downstream pathways leading to an increase in glycogen synthesis, drop in glycogen breakdown, and GLUT4 transport to the cell surface in adipose tissue and skeletal muscle. Remember, IRS1 is activated through tyrosine phosphorylation. So what tumor necrosis factor alpha, or TNF-alpha, does, it stimulates serine phosphorylation of IRS1, and that basically inactivates it. The other interesting thing, of course, is that hyperinsulinemia, the tumor necrosis factor, and free fatty acids, and you see an elevation of free fatty acids in obesity, they all trigger insulin serine phosphorylation of IRS1 through different signaling molecules, but the end result is they all downregulate downstream insulin functioning, therefore leading to insulin resistance, therefore leading to hyperglycemia. The other one that we'll talk about is CRH, or corticotrophic releasing hormone. This is also released from the developing placenta, stimulates ACTH secretion by the anterior pituitary, and of course that goes on to release or stimulate the release of cortisol from the adrenal cortex. And cortisol has anti-insulin effects. So an increase in ACTH will lead to increased pigmentation around the areolae and nipples because of its melanocyte stimulating activity, therefore enhancing melanin levels. It'll also lead to an increase in cortisol, which reduces collagen synthesis, also leads to protein breakdown. So therefore, we start to get abdominal striae or stretch marks, because remember, this cortisol also potentiates this through its proteolytic effects. Cortisol also downregulates the number of insulin receptors. Therefore, with less insulin receptors, we have less maternal glucose uptake, and therefore we start to get an increase in blood glucose levels, and therefore more glucose delivery to the fetus. But it also causes, or is partly responsible for the diabetic effect during pregnancy. So, like we've said, the placenta secretes lots and lots of things. Another thing it secretes is estrogen, progesterone, and HPL, or human placental lactogen. Now, these hormones antagonize the effects of insulin. In other words, they act against insulin. And that means we have a 40% reduction in insulin sensitivity. And it's estimated that it's about decrease of 40% within the third semester. And therefore, insulin levels, we've got a decrease in insulin sensitivity. So, of course, to compensate for this insulin resistance, insulin levels increase. And they increase by about threefold. And it's estrogen in particular that seems to increase insulin sensitivity normally, but in pregnancy appears to increase insulin resistance. Progesterone in pregnancy may also increase that insulin resistance. Remember, of course, that estrogen increases insulin sensitivity, but pregnancy increases resistance, and progesterone increases that resistance. But of course, following delivery, those placental hormones, that's your estrogen and your progesterone, they're removed, and insulin sensitivity improves, blood glucose levels reduce back to normal, and the diabetes has disappeared. Hence why a cure, in inverted commas, for gestational diabetes is delivery. What about the role of HPL, human placental lactogen, in insulin resistance? Well, HPL is first detected in maternal blood at around about 3 weeks. And HPL levels increase in relation to the fetal and placental growth. And it's got some very important roles. It decreases glucose transport into those maternal insulin-sensitive cells, therefore increasing blood glucose levels, which allows the glucose to be available for fetal growth. It also stimulates lipolysis, and therefore your free fatty acids are available for the mother, and therefore to have increased energy. It also stimulates proteolysis, so therefore amino acids are available to the fetus for growth. And it stimulates the IGFs, that's your insulin-like growth factors, which allows growth of fetal soft tissue and bone. So the growth hormone doesn't play a massive role of growth within the fetus, and instead it appears that it's HPL that plays a much bigger role. But what about insulin resistance in pregnancy? And so now we're going to look at the pathophysiology of normal insulin resistance in pregnancy as a summary. So we get an increase in HPL, an increase in estrogen, an increase in progesterone, TNF-alpha and cortisol. They all have, through different mechanisms, anti-insulin properties. They decrease the body's sensitivity to insulin. They increase the mother's blood glucose, and this is available to the fetus. So this is exactly as we would expect. This is normal. But the problems arise when there is excessive insulin resistance, or there's not enough insulin produced to overcome the increased resistance. So here we have a review question for you. Which of the following statements regarding insulin sensitivity are correct? Press pause and have a think. Number 1. Insulin resistance is normal in pregnancy as it increases maternal blood glucose levels which can be delivered to the developing fetus. That's correct. Number 2. On binding the insulin receptor in adipose tissue, insulin signaling leads to increased glycogen synthesis. That is incorrect. There is no glycogen storage in adipocytes, so therefore no glycogen synthesis. Number 3, on binding the insulin receptor in hepatocytes, that's your liver cells, insulin signaling stimulates gluconeogenesis. That is incorrect. It inhibits gluconeogenesis. You don't want to make more glucose. Number 4, estrogen and progesterone increase insulin resistance in pregnancy. That is correct. In the second half of this session, we're going to look at the pathophysiology of gestational diabetes mellitus. So, of course, obesity, as we've talked about, is a major factor in the development of gestational diabetes. We've already gone over some of the mechanisms behind that. Because adipose tissue, whilst years and years ago used to be thought to be just a very quiet organ where fat was stored, it's actually a very, very active organ. Secretes many hormones and cytokines and adipokines and other messengers that affect homeostasis. And some of those things that it produces, that obesity and the excesses of insulin resistance during pregnancy can be caused from the TNF-alpha that's secreted from adipocytes, particularly those visceral adipocytes. That's your central obesity, so the fat around your organs. We've already talked about this. So in obesity, there's an increased secretion of TNF-alpha, which means we get an increase in insulin resistance, which means we get an increase in blood glucose because of the obesity above and beyond the TNF that is being secreted from the placenta. And so, in other words, this is that whole diagram that we've talked about with regards to insulin signaling. And so remember, we have placental TNF-alpha, nice and normal. Obesity-related TNF-alpha, not quite so good. And the two of them have an additive effect to serine phosphorylate and therefore inactivate the insulin receptor substrate 1. And if we inactivate that, we inactivate or decrease all of these pathways in skeletal muscle, in liver and adipose tissue, which means we have an increased blood glucose that becomes hyperglycemic and into the diabetic range. There are actually certain polymorphisms. Polymorphism just means common mutation in TNF-alpha that are associated with insulin resistance. So some people will have mutations or polymorphisms in that TNF-alpha protein that can enhance serine phosphorylation. So that's just kind of an unlucky genetic polymorphism that some people have. So another one that we're going to talk about, a very important one, is adiponectin. So this is a hormone secreted by adipose tissue that circulates within the blood. And adiponectin does lots of things, but it activates a whole series of signaling cascades in cells. But the end product is to increase glucose uptake into muscle. That means it lowers blood glucose levels. It increases fatty acid oxidation by muscles in the liver. Therefore, it lowers fatty acid levels in the blood. And it decreases gluconeogenesis in the liver, therefore decreasing blood glucose. So adiponectin really reduces blood glucose levels and reduces free fatty acids floating in the blood. Remembering, of course, that free fatty acids are involved in insulin resistance, and adiponectin is lowering them. So it's anti-diabetic, if you like. So the problem is that the elevated TNF-alpha seen in obesity, which is released from your adipocytes, inhibits adiponectin secretion. So most people would think more fat cell, more adiponectin. But what actually happens is more fat cells, more TNF, less adiponectin. So therefore, the decreased adiponectin, which is seen in obesity, leads to increased fatty acids. And remember what the fatty acids do in this bottom right corner? Those free fatty acids serine phosphorylate the insulin receptor substrate 1. They inactivate it, just like the TNF from the adipocytes. They inactivate it, which means we have increased fatty acids, increased glucose, which means we have insulin resistance and hyperglycemia. And of course, as you might expect, people who lose weight tend to get higher adiponectin levels. And in fact, anorexic have very, very high levels of adiponectin. It's also interesting that women have significantly higher levels of adiponectin than males, so therefore, in the grand scheme of things, not thinking about pregnancy, they're less likely to get diabetes mellitus or type 2 diabetes mellitus. And it is actually thought that adiponectin or molecules or drugs that are very similar to it could be potential treatments or management methods for diabetes mellitus. So, if we're looking at a summary of what's happening at this point in gestational diabetes, remember, a lot of this is actually very similar to type 2 diabetes mellitus. So if you understand type 2 diabetes mellitus pathophysiology, you really understand gestational diabetes mellitus pathophysiology, because they are basically the same thing, with a couple of exceptions. There are extra things produced from the placenta, which is normal in pregnancy. So in visceral obesity, you have an increase in your TNF-alpha, which is being secreted from your adipocytes. That binds, of course, to a TNF receptor. We have a decrease in adiponectin levels. That's because TNF is inhibiting the release of adiponectin from the adipocytes. And that leads to an increase in our free fatty acids that are floating around. And those two together cause insulin resistance. They stop the insulin receptor substrate 1 from working properly. It's no longer as active. And because that's no longer as active, you get a decrease in glucose uptake and a decrease in glycogenesis, so decrease in the synthesis of glycogen within the liver. And that means you get hyperglycemia because more of it's floating around in the blood. The adiponectin in itself can lead to hyperglycemia, and the compensation for the hyperglycemia is an increase in insulin secretion, so you get hyperinsulinemia. But over time, in particular when you're thinking about type 2 diabetes mellitus, it leads to beta cell failure, and TNF in itself binds to TNF receptors on the pancreas and is also pancreatic beta cells and is also toxic to those cells. And as you start to get pancreatic beta cell failure, of course, can't produce the insulin, leading to hypoglycemia and gestational diabetes mellitus. But like I said, this mechanism is pretty much the same because it's all about visceral obesity. This is exactly the mechanism that occurs in type 2 diabetes mellitus. But it also occurs in gestational diabetes, which is type 2 diabetes mellitus during pregnancy. Okay, a couple of questions for you. Which of the following are true regarding gestational diabetes? Press pause and have a little bit of a think. Tumor necrosis factor 1 secreted by the placenta in the second trimester leads to insulin resistance because it serine phosphorylates IRS1. That is correct. It's secreted primarily in the second and third trimesters. Human placental lactogen, or HPL, produced during pregnancy stimulates lipogenesis and therefore increased delivery of nutrients to the fetus. False, it stimulates lipolysis, breakdown of triglycerides to free fatty acids, which the mother can use as an energy source, and the baby can potentially use as an energy source as well, of course. HPL stimulates IGF, that's insulin-like growth factors, release, which enhances soft tissue growth in the fetus. That is correct. And it's normally growth hormone that stimulates insulin-like growth factor release, but in the baby or the placenta, in the fetus rather, it's HPL that stimulates IGF release. Gestational diabetes is most likely in overweight women due to increased TNF-alpha release from adipocytes. That is correct. And that TNF is toxic in itself, but also reduces adiponectin. Oops, which is the next question? Should have read that really. Adiponectin secretion is inhibited by elevated TNF, which leads to decreased insulin sensitivity. True, because adiponectin enhances insulin sensitivity.